Our next speaker, talking about adjuvant endocrine therapy for premenopausal women, risk stratification, type and duration, is Prudence Francis from Melbourne, Australia.
Thank you very much, Karen, and it's a great pleasure to be here at the St. Gallen meeting in Vienna. It's always a pleasure to attend this meeting. Now I'm going to talk you through a topic that I think remains, even for me, a challenge in the clinic, and I'm sure it remains for many of you a challenge. And this is around the choices that we have for adjuvant endocrine therapy for premenopausal women. So it's now just over 20 years since the Oxford Overview meta-analysis published in 1998 clearly documented that adjuvant tamoxifen could significantly reduce recurrence of ER-positive breast cancer in women under 50. And that analysis also suggested a greater effect for 5 years of tamoxifen than 2 years. Then fast forward to 2011, and their follow-up publication showed that tamoxifen for 5 years, in fact, could reduce 15-year breast cancer mortality by approximately 1/3 in women who were under age 45 at the time they were randomised to tamoxifen or no tamoxifen. So here are the plots that show the effect on breast cancer recurrence and breast cancer mortality in women under age 45 with ER-positive tumours randomised to control, which was no tamoxifen, or 5 years of tamoxifen. And you can see that there are quite striking effects. So when we're thinking about escalating adjuvant endocrine therapy beyond tamoxifen alone, it's on the background of quite a strong effect already, so that if we're going to show any improvement, we need to do it over and above this effect. Now, I'm going to take some time to talk you through the most recent data from the SOFT and TEXT trials, and I want to emphasise these trials were premenopausal trials, and unlike the topic that Hope Rugo addressed yesterday in women with borderline estrogen receptor staining, these trials only enrolled women, premenopausal women, who had at least 10% of cells staining for estrogen or progesterone receptor. SOFT was really addressing the primary question of whether adding ovarian suppression in women who remained premenopausal to tamoxifen would add benefit. And then the joint analysis in SOFT and TEXT was addressing the question, if you're going to give ovarian suppression, is the aromatase inhibitor or tamoxifen the better partner? So the trial designs, the TEXT design on top and the SOFT design below. You can see that they have two common arms where patients were assigned to tamoxifen and ovarian suppression, or the aromatase inhibitor exemestane and ovarian suppression. But SOFT had a third arm, the control arm of tamoxifen alone for 5 years. Now, in both trials, they were stratified according to whether patients received chemotherapy or not. Chemotherapy was not randomised. It was decided by the doctor in conjunction with the patient, and you could either receive it or not. But to enter the SOFT trial, the women had to have a premenopausal estradiol level done at a local laboratory within 8 months of completing chemotherapy to be allowed to participate. Now, here's the most recent data from the SOFT trial. We've now got 8 years of median follow-up, and this was published last year. And the trial now shows a significant improvement in disease-free survival with the combination of ovarian suppression and tamoxifen as compared with tamoxifen alone. And so that's the red curve in the middle, to the tamoxifen ovarian suppression, and the black curve at the bottom is tamoxifen alone. And the blue curve on top is the arm with exemestane, the aromatase inhibitor, plus ovarian suppression. So you can see a slight further improvement in disease-free survival. Now, the relative effect of adding ovarian suppression to tamoxifen was similar in the no chemotherapy cohort and the chemotherapy cohort. However, the baseline risk factors in these patient populations were different. The women who received prior chemotherapy and SOFT had higher risk clinical and pathologic features and therefore had a higher absolute risk of recurrence. Here in red, I've shown you the absolute improvement in disease-free survival that was achieved at 8 years with the addition of ovarian suppression to tamoxifen compared to tamoxifen alone. And you can see that both cohorts derive some absolute improvement, but it's a larger absolute improvement in the chemotherapy cohort who are at higher risk for recurrence. In the blue, you can see what happens, the absolute improvement in disease-free survival for the aromatase inhibitor exemestane with ovarian suppression compared to tamoxifen. And again, you can see that both the no chemotherapy cohort and the chemotherapy cohort derive some improvement, but it's a larger absolute improvement in the higher risk patients. Now, I'm just looking here at the no chemotherapy cohort. So these are patients, if you look at the bottom, the box at the bottom, the cohort had a median age of 46. There were very few that were under age 40. They were mostly T1, node negative, low to intermediate grade tumours, and they nearly all were progesterone receptor positive. So these are good clinical pathologic features that allowed the doctors to be comfortable that patients might be randomised to tamoxifen alone. And in the secondary outcomes, you can see that there are very few distant recurrences and deaths in these patients with tamoxifen alone, suggesting that escalating this adjuvant endocrine therapy in this particular type of patient cohort, a low-risk cohort, does not make a big impact on these secondary outcomes, even though there was some small improvement in disease-free survival. Now we're looking at the prior chemotherapy cohort. Remember, have a look at the features at the bottom. Median age of 40 years, so more young patients, more T2 tumours, more node-positive tumours, more grade 3 tumours, more HER2 positive. And if we look now at distant recurrence and overall survival, you can see a little bit of white between the curves, showing that you can get some incremental improvement in distant recurrence and overall survival at 8 years by escalating the adjuvant endocrine therapy. Now, in the joint analysis of soft and text, we looked at the question of if you're giving ovarian suppression, is it better to give the aromatase inhibitor exemestane than tamoxifen? And you can see that at 8 years, there was still a significant improvement in disease-free survival, favouring the aromatase inhibitor and ovarian suppression arm. But if we look at overall survival at 8 years, you can see that there is currently, for these patients who all received ovarian suppression, currently no difference in overall survival according to the oral adjuvant endocrine therapy component. Now, we have done analyses focusing on the HER2 negative population now that we have these 8-year data. And the reason for this is that these patients had the current contemporary therapies available to them at the time they were randomised. The HER2 positive patients, the trial started randomising in 2003, which was before the routine use of adjuvant HER2 targeted therapy, and so not all the HER2 positive tumour patients were treated in the way that we would in a contemporary practice. So we focused in on the HER2 negative population, and here I'm trying to show you what's happening with distant recurrence-free interval at 8 years in the joint analysis. And you can see here for soft and for text that in the higher risk patients, these are those who were given chemotherapy as decided with their doctor, that we have 5 to 7% absolute improvement in the chance of being free from a distant recurrence at 8 years in the chemotherapy cohorts. But if you look at the lower risk patients who did not receive chemotherapy, you can see there are very small improvements in distant recurrences by escalating to an aromatase inhibitor rather than tamoxifen. Now, I would argue that overall survival in an estrogen receptor positive premenopausal population is immature when you look at it at 8 years, but I'll just show you where we're up to in the HER2 negative population, allowing for the fact that we are following these patients longer. But if we focus on the HER2 negative population who were given chemotherapy because we believe they were at sufficient risk to need chemotherapy, this is what the numbers are showing at the moment. So at the moment, the arms that have aromatase inhibitor exemestane plus ovarian suppression numerically are favoured for overall survival. And I'm not saying that everything's significant, I'm just showing that numerically for HER2 negative, it looks like in the higher risk patients at the moment, this arm is doing better. And obviously we need longer follow-up. Now I want to talk a little bit about risk stratification, and I want to talk about composite risk. And really, composite risk, some people may think of as complex, but really it's talking about the clinical pathologic features that we all know and thinking about combining these in models that would allow for any individual patient to think about whether they might have a higher or a lower risk of recurrence. Now, Meredith Reagan has published a very elegant paper in the Journal of Clinical Oncology on this in 2016, and unfortunately Meredith's not here to see me talk about this work. But basically, in her model of composite risk, this publication referred to the chance of having an invasive breast cancer event at 5 years, the so-called breast cancer-free interval. And it was calculated for each HER2-negative patient using a Cox model and incorporating the clinical pathologic features that we think about every day in our multidisciplinary meeting. So thinking about age in 5-year cohorts, thinking about nodal status, tumour size, tumour grade, Ki-67. Now, this was centrally reviewed, so we may not all have this in our clinic, but Ki-67 was available to us, estrogen and progesterone receptor, the degree of positivity. And I'll just show you an example of how some of these factors might affect the chance of a patient having an invasive breast cancer event in these trials in the HER2-negative population at 5 years. So you can see that in the bottom curve, which is the light blue curve, which is women under age 35, you can see they have a much higher chance of having an invasive breast cancer event at 5 years than the women that are up there in the 45 to 50 or 50 and older age group. So age, very young age, does appear to be quite powerful here. Here's examples of tumour size and nodal status, and what you can see, even if you can't read all the data, is the blue line for nodal status, which relates to the 4 or more node positive disease. That clearly is a powerful also prognostic factor when we're thinking about composite risk. Looking at grade, high-grade tumours, grade 3 tumours, again, this is affecting your risk of having an invasive event. Ki-67, as done by Beppe Viale, clearly comes out very nicely and shows that you can actually separate if it's done centrally. And then we're looking at estrogen and progesterone receptor staining. And in the progesterone receptor staining, the bottom blue line refers to less than 20% of cell staining. And again, that contributes to a higher composite risk of recurrence. So I'm just giving you now examples from the more recent presentation that Meredith did at ASCO last year, looking at the chance of having a distant recurrence at 8 years. On the left is an example of a woman at low composite risk. She has all nice features from soft and text. She's over 40, node negative, T1 tumour, good ER and PR staining, grade 1 tumour, good Ki-67. So she's going to do very well with tamoxifen alone, has a low composite risk. If I take that same woman and move her to the middle, to the intermediate group, what's happened here? Okay, she's gone from having negative nodes to having 1 to 3 nodes. She's gone from having a grade 1 tumour to a grade 2 to 3 tumour. Her Ki-67, instead of being below 14%, is now above 20%. And now her composite risk is just beyond, just to the right of the median composite risk of all the patients in the soft and text trials. Then if we move further to right and go to a very high-risk situation, what's happened here in her clinical pathologic features? So we've here now made the woman under 40 years of age, we've given her a T2 tumour, and her PR staining is now below 50%. So this woman now has a very high composite risk. So these are examples of thinking about low or median or high composite risk and how you might decide who might need lesser or more adjuvant endocrine therapy. So I want to introduce the concept in risk stratification that there is a larger absolute benefit from the escalation of adjuvant endocrine therapy in patients who have a higher composite risk of recurrence. And so here's a step analysis and looking at freedom from distant recurrence at 8 years in the text trial. And over to the right, circled in green, you have the chance of having a distant recurrence at 8 years in the text chemotherapy population. And far to the right are the patients at highest composite risk, those bad clinical and pathologic features. And the blue line on top, which is the aromatase inhibitor exemestane with ovarian suppression arm, is quite widely separated from the tamoxifen and ovarian suppression arm. But if you move further to the left, to the midline where that red vertical line is, you can see that there's very little difference in which oral endocrine therapy you got. So in fact, your absolute benefit from escalating to an aromatase inhibitor with ovarian suppression in the women at highest composite risk might be quite large, of the order of 15%, but might be minimal in a woman who has low risk features. And the similar things can be seen in soft, except that we've got three curves here. We've got the tamoxifen alone at the bottom in green, we've got tamoxifen ovarian suppression in the middle in red, and on top again the exemestane and ovarian suppression arm. And recall that all these data are taken in the HER2 negative population. So I would argue that for premenopausal hormone receptor positive HER2 negative tumours, if you're at a very high risk of recurrence, then exemestane, the aromatase inhibitor with ovarian suppression, appears at the moment from our data to be a more effective endocrine therapy than tamoxifen with ovarian suppression or tamoxifen alone. And for the women who are at the very highest risk of recurrence, that might be a large absolute benefit, while for other women it might be negligible. Now, I want to remind you about very young age, and here's the 8-year data that we have in terms of freedom from an invasive breast cancer event or freedom from distant recurrence. And tamoxifen alone is not performing as well as either of the ovarian function suppression arms in the soft trial for these young women at 8 years. And so basically, among those women who were assigned to tamoxifen alone, and bearing in mind that nearly all these women received chemotherapy due to the prejudices of the doctors who were treating young women, that if you got assigned tamoxifen alone, more than 1/3 had an invasive breast cancer event by 8 years, and more than 1/4 had had a distant recurrence. So in my own practice, I consider ovarian suppression in these very young women if they have hormone receptor positive breast cancer. And if they don't tolerate an aromatase inhibitor with ovarian suppression, I'd try de-escalating to tamoxifen with ovarian suppression before de-escalating to tamoxifen alone. Now, risk stratification, it's important not only to identify those at high risk, but what about those women who are at low risk, because we want to limit the overtreatment in terms of endocrine therapy. Now, if a woman in my clinic had these sort of clinical pathologic features, and in Australia we don't have routine access to multi-gene assays, so unless a patient opts to self-fund, this is basically we're using our routine clinical pathologic features. And if a woman had all of these features, I would be comfortable that tamoxifen alone was an appropriate systemic therapy. And particularly when the older premenopausal age, she might naturally enter menopause within the next 5 years, so she's automatically giving herself ovarian function suppression potentially. So do you actually need any adjuvant endocrine therapy if you have a low-risk premenopausal breast cancer? Well, I would recommend adjuvant tamoxifen in general unless there's a contraindication, and particularly if the woman has remaining breast tissue, because tamoxifen does reduce the risk of an isolated local recurrence, and that's relevant in breast-conserving surgery. And tamoxifen is also relevant for preventing future new breast cancers that might happen down the track. And if you look at the Oxford overview data for women who were randomised to receive 5 years of tamoxifen under age 45 as compared to those who received no tamoxifen, at 15 years follow-up, the chances of having a contralateral breast cancer, the absolute difference was around 3%. So thinking about duration, when you're thinking whether to go longer than 5 years, I would consider the baseline tumour risk, the age of the patient, their tolerance, and also their fertility and their pregnancy aspirations. There is really only evidence to support 5 years of ovarian suppression at this time, but there is evidence to support 10 years if you're giving tamoxifen from the Atlas trial, and there's also evidence from the MA17 trial to support a switch strategy. But I would beware in women under age 50 with intact ovaries, because there is a significant rate of ovarian recovery in these young women. The Atlas trial clearly showed that there was a reduction in recurrence and breast cancer mortality by extending tamoxifen to 10 years instead of 5 years. And the absolute difference is about 4% for recurrence and 3% for breast cancer-specific mortality, with a significant improvement in overall survival. In Atlas, only about 10% were premenopausal at study entry, but there appeared on the forest plot to be relatively similar efficacy. The other factor to take into account is the age at which a patient was when they were diagnosed. And this analysis from the Oxford group suggested that women who were under 35 years of age had a higher risk of having these late distant recurrences in years 5 to 20 after 5 years of adjuvant endocrine therapy, so they may be candidates for longer therapy. So I'd like to acknowledge the cooperative groups that have contributed to the soft and text trials. These have truly been an international collaboration. I'd like to acknowledge Meredith Regan, the study chairs, and all those who've helped to support the trials and including their long-term follow-up. And we are continuing to follow these women. Thank you.
I think we can do a question, don't we? Thank you, Prue. You stayed on time, so I think we can have a question or two if people want to come to the microphones.
Microphone 6.
Microphone 6.
This is Watanabe from Japan. Thank you very much. Your excellent presentation. My question is about the duration of the LH-LH agonist. When you started to use the LH-LH agonist at the age of 35, are you going to give the agent until the average time of menopause, or 5 or 10 years as fixed duration? Could you give us your opinion?
Thank you for your question. So in the soft and text trials, patients were to receive ovarian function suppression, and in the case of the LH-RH agonist, this was with triptorelin, and it was for 5 years from randomisation. So the evidence is available for 5 years. After the protocol planned period of 5 years, the protocols were silent as to what would happen to women. So clinicians and patients were free to choose whether to have a baby, whether to continue tamoxifen or something else. I think there are some risks with continuing long-term treatment to induce menopause on cardiovascular health, sexual health, bone health. And so in my routine practice, I don't insist on women having permanent ovarian suppression because we don't have randomised data to support that. I can imagine that perhaps if you had a very high-risk, locally advanced breast cancer, you might be tempted to think about this and discuss it with the patient, but it is not evidence-based.
Thank you.
Thank you. Microphone 6 or 5.
Thank you. In your practice, could you say a word about intravaginal estrogen to deal perhaps with dyspareunia, vaginal dryness, et cetera? What do you do with these young women on ovarian suppression?
Okay. Yes, this is a very real problem. I think the problems of libido and dyspareunia and sexual dysfunction are not to be underestimated, and I'm sorry for time I did not focus on the toxicities. In the protocol, in fact, women were allowed to receive vaginal forms of topical estrogen if non-hormonal measures were not sufficient to alleviate their distress. So they were allowed in the protocol. In my own practice, I think if a woman is suffering from poor sexual quality of life due to the treatment, and if she's on an aromatase inhibitor, I would sometimes consider dialing back to tamoxifen and ovarian suppression, and I would probably be more comfortable with the use of vaginal estrogen in that context than I would be with the aromatase inhibitor, because there is the possibility that the very low, ultra-low estrogen levels that we're expecting in the premenopausal woman might not be achieved if there is a lot of vaginal estrogen. But again, I think it does need to be individualised, and certainly tamoxifen causes less dryness and less problems with low libido.
Prue, I want to be sure that I and the audience understand completely. It appears to me that you all have used chemotherapy or not as a surrogate for prognosis. You don't believe that there's a biological interaction between chemotherapy and whether someone has AI versus TAM, right?
No, I mean, if we looked at the hazard ratios and disease-free survival in soft, they are identical for the no chemotherapy cohort and the chemotherapy cohort for the question of ovarian suppression added to tamoxifen versus tamoxifen alone. So it's the same relative effect and a different absolute effect. So chemotherapy is a surrogate for higher composite risk.
So the implication of my question is it's actually the risk index, or however you want to determine what the risk is, not whether or not the patient got chemotherapy, that would determine whether you give them more aggressive. And I think that's an important distinction that I have seen confused in consults I've seen. So.
Yeah, but having said that, I mean, one comment I would make, and I haven't gone through it today, the text trial in which everybody got ovarian suppression, there are higher risk patients than in soft in the no chemotherapy cohort. Just over 20% of those patients are node positive in that no chemotherapy cohort.
Thank you. Prue?